Moving on, up until now we have discussed signs, symptoms, public health awareness, management and prevention of stroke. Another important aspect of stroke care is quality and accreditation and standardization. The quality of care provided to patients can be life-altering, and our next panel will address this key aspect. The topic of our next panel discussion is quality-driven care, accreditation and standardization guiding stroke care excellence. Please give a huge round of applause to our distinguished panelists. May I please invite Dr. Meenakshi Gauri Shankar, consultant neurologist, stroke specialist, neurosonologist, Senthil Multi-Speciality Hospital and Erode Neuro Center. Dr. Arvind Sharma, Secretary, Indian Stroke Association and Senior Consultant Neurology, Zydus Hospital. Mr. Neeraj Lal, Chief Operating Officer, Apollo Hospitals, Technical Committee, Stroke Standards, QAI. Dr. Sanjay Saxena, Senior Director, Neurology, Max Hospital. Professor Rajinder K. Dhamija, Director, Indian Institute of Human Behavior and Allied Sciences, Government of NCT, Delhi. And Dr. B.K. Rana, Founding CEO, Quality and Accreditation Institute. Dr. B.K. Rana will be leading this panel discussion as a session moderator. Over to you, Dr. Rana.
Thank you very much. Thank you all of you for being here. Thank you everyone all there. Are you there here? Very well? Mentally, physically and spiritually? All three confirmed? Thank you very much. Then you will get a lot of things from these 5 ladies and gentlemen, 1 ladies and 4 gentlemen, I'm sorry. Yeah, that's good sign of you can take off a stroke if you are suffering from or you want to be, not to be. So thank you very much, all panelists, and I think very well designed program, and we have been hearing a lot of experts since morning on different aspects. Primary theme of innovation, partnership, and policy. So now this session is about standardization in stroke care and how we can make use of quality, and accreditation is making it better. So I have some of the questions for the panelists, and which will give us a different perspective of the topic which we are talking about. So thank you once again. So I'll pose questions which may not be knowing to you before, but please try to attempt. And the whole purpose is to create awareness and to entertain all of them. So if you are at the end of the panelists, we are able to entertain all of them sitting here, our purpose is served about standardization, which is about innovation, partnership, and the policy which you guys will be suggesting or advising to all of us. So thank you so much. So I'll come to a hardcore physician, the neurologist, Dr. Saxena first. And the question to Dr. Saxena is about what are the key challenges in ensuring standardization in stroke care in any hospital? Over to you, Dr. Saxena. Thank you.
Thank you, Dr. Rana. And I must compliment about this concept, the movement which has started. And I think this is the movement, just the beginning, and we have to move faster towards achieving a better care for our stroke patients. So we have been discussing about the basics of understanding of the stroke, recognition, prevention, and the treatment part. But when it comes to dealing with the patient who arrives in a hospital, which is supposed to be a stroke care center, then what are the challenges we face? So within house, you have to have a quality control team to monitor and guide clinicians, especially the leader being neurologist in that case. And that quality parameter would drive this concept of being a stroke recognized center or accredited center. So for example, in a hospital where a patient arrives in the emergency department and is attended by the physician after 10 minutes, so that is where the purpose is probably getting lost. So it is important for the whole hospital staff to be sensitized right from the person who is at the security gate or the person who is manning the emergency department, because where I work, it's a very busy center and hospital in Delhi, very densely populated hospital. So there, it starts from there. So as soon as patient should come, it should be evaluated as early as possible, and then the kind of awareness about the stroke should be announced immediately in the hospital, so that the relevant people, they are available, and the patient can be taken up for the initial evaluation, and not letting loose even a single minute. We all know after having suffered a stroke, brain gets damaged becomes poorer by 1.9 million neurons every minute. So there is the concept of as soon as possible, reflexes should be very quick. Within no time, we should be able to evaluate the patient. We should have check at all the levels. So that is what I think Dr. Rana wants me to highlight. They should be checked at every level so that we don't lose even a single minute before we consider the patient for the therapy, irrespective of whatever the presentation of the patient is.
Thank you very much, Dr. Saxena. Well defined in aspects how we should initiate, the evaluation and so on. So thank you so much. I move to Dr. Dhamija, Director of IHBAS in New Delhi. As a leader running an organization with so many patients around the day, my question to you, Dr. Dhamija, is around the government's perspective in terms of formulating policies around stroke care and what government is doing or government should be doing. Over to you, Doctor. Thanks.
Thank you very much, and good afternoon to everyone, all of you. At the outset, I must express my gratitude and thanks to Voice of Healthcare, Dr. Sharma, Indian Stroke Association, for having me here and interacting with the stalwarts in the stroke care in the country. It's really a privilege and honor for me to be here amongst you. As a director of the Institute of Human Behavior and Allied Sciences, which is the largest neuropsychiatric hospital in the country and probably in the world, in terms of number of patients we have around 3,000 patients coming only in the OPD for neurology and psychiatry. So you can imagine the 1,500 patients coming for every day in neurology, and bread and butter of every neurologist is epilepsy followed by stroke. So strokes becomes a major chunk of patients coming in the outpatient. I'm not talking about the emergency departments. The emergency is a different altogether, and we have the system in place which is called stroke code. So any patient who is brought in the emergency with a possible diagnosis of stroke, so that the system gets activated and all the budgets go on right from the resident doctors to the radiologists to the stroke physicians, neurologists, and the ICU. So that system is working there for many years, and we have been awarded 2020, 2021, 22, 23 from the Angels Initiative and the World Stroke Organization. So that hospital brings a model for all of us to how the stroke care should be implemented. And mind you, this is not a private hospital, this is a government hospital run by the government of Delhi with full grant in aid. It's an autonomous like AIMS, but funding comes from the government of Delhi. Now, as a policy maker, as a government perspective, so the government of India is running the National Program for Control of Cancer, Diabetes, Cardiovascular Disease and Stroke that is running for many, many years now. It has been renamed as a National Program for the NCD, Prevention of Non-Communicable Disease. And stroke forms again a major chunk of that. That is one thing which the government is implementing across the country. And recently, a National Health Authority has included stroke in the Universal Health Coverage, UHC. That is again a very big, ambitious program from the Government of India, Ministry of Health and Family Welfare, where we aim to provide the accessibility, availability, affordability, and adaptability to the local conditions. That is 4 A's. It should be easily available, it should be affordable, it should be accessible to all, equitable, and of course, acceptable and adaptable to all people in that area. So that is from the perspective of the national program. But what we have been doing at an individual level also, at an institutional level also. So what I personally feel, and I have written a lot in the editorials on the national newspapers like Times of India and Hindustan Times, that we need to strengthen our district hospitals. Our district hospitals in 90s, rather late 80s or 90s, they were very good hospitals. Most of the surgeries were being done in those hospitals at that particular time. Our doctors were trained to do surgeries, trained to handle all kind of emergencies. But after 90s, the district hospitals have become in shambles. The buildings are in very poor state. The infrastructure is crippling. The doctors are not going there because of the incentives now in private sector. And that is why the government has come up with plans to give incentives for the doctors to build up infrastructure so that we can augment, we can strengthen district hospital. And one of the contribution in stroke care is to have a CT scan in all the 760 district hospitals. Whether it is a public-private partnership in Punjab or in Delhi, again, the public-private partnership for CT scan and MRI both. So the target is each district should have a stroke unit along with a CT scan and at least a physician trained in a stroke care. So that is again a policy which is being rolled out across the country. And the last thing is that the stroke awareness at the larger level in the regional remote areas, given the inequitable neurologist population, we have been hearing that we have 3,000 neurologists in the country, and most of these neurologists are concentrated in the metropolitan areas, more in south, less in north, but mostly in Delhi, Mumbai, Ahmedabad, Chennai, Bangalore, Calcutta. All these major big cities are having 90% of neurologists and very low numbers of neurologists in the remote and regional areas, and very few neurologists at the country. The government of India has now increased the number of DM neurology seats and DNB neurology seats. So we have a 700 neurologists every year now in the pipeline. That will make the capacity to produce neurologists in the country so that the neurologists should have a equal representation, not only is concentrated in the big cities, but also at the tier 2 and tier 3 cities, so that the people don't have to travel 200 kilometers or 300 kilometers or 500 kilometers to reach to a hospital which is stroke ready hospitals or a primary stroke centers. That is the other thing. We have been advocating that each physician should be trained in stroke care and rehabilitation. So there has to be continuum of care. Continuum of care means right from the hyperacute to acute to subacute to rehab to the integration in the community so that the productivity or the function of that person is restored, as we saw in the morning in the inaugural session. So the continuum of care has to be ensured, and that is the mandate of the government or the policy makers to make available that continuum of care. It is not only the acute care, not only the thrombolysis, not only the thrombectomies. It is again important to have a rehabilitation program, which we are lacking. I have worked in Australia for many years where there is a structured rehabilitation programs for the stroke survivors in the hospitals, in the subacute centers. However, in our country, because of the logistics and because of the family system, we are more of a giving rehabilitation in the family, in the community. But that can also be done. There is a model. Dr. Nirmal Surya has done that model of community-based rehabilitation program in the stroke, but that has to be under supervision. Whether it is telemedicine, telestroke, hub and spoke model, or tele-rehabilitation. Tele-neuro rehabilitation again is coming up in a big way with a digital revolution with widespread internet connectivity, mobile phones, and the gadgets of virtual reality. So this will be a last mile care in the continuum of care of stroke. So these are the things which I think as a government policy makers, as a leader in the hospitals, we have to ensure that each and every patient of stroke gets the care he deserves and care he has right to do it. Lastly, my suggestion and my humble request would be, if somebody is having a warning signs of stroke, likely to be a stroke, please rush to the hospital rather than going to a GP or going to a hospital which is not a stroke ready hospital and wasting time, so that window golden time is brain is not wasted, or these patients are left out of that opportunity for the acute stroke care. Thank you very much.
Thank you, sir. Thank you very much for giving us a lot of information and also advice. And happy to note the policies government under NCD, National Policy NCD, which covers stroke as well. And I had a chance to look at that policy, quite ambitious. But happy to note that about National Health Authority initiative to take stroke in actually as a part of Universal Health Coverage, USC. And I'm delighted, actually. I usually says universal health coverage means accessibility, affordability, and quality. It's a three-legged stool. I'm happy that you added the fourth fourth leg to the stool is about adaptability or acceptance about the program. So thank you so much for giving that insight to us. I come back to you a little later. I want to move to the Dr. Arvind Sharma. The topic of the panel is about standardization, quality, accreditation. My question to you is, what is the current scenario in stroke care about quality improvement and accreditation perspective, which is going on at the moment, so our audience can also get updated about that. Over to you, Arvind. Thank you.
Thank you, Dr. Rana. Thank you very much, and thank you, VH, for inviting for this panel. And it is very close to the heart. And Dr. Dhamija has given a very great insight about all the policy thing. Now, understanding about the stroke across India, more than 1.2 billion people, and how many neurologists we are, right? There are 3,000 or 4,000 neurologists. Number of seats are increased, as is told by Dr. Dhamija, that it will be 700, but still to meet that need to treat the stroke in the form of acute care or the chronic care, as it was given very good insight about preventing the stroke in the form of controlling the blood pressure by the Indian Hypertensive Initiative by Dr. Ganesh. So those are the things for the prevention, acute treatment, chronic. Everyone is doing their part in pockets. But there is not a uniform policy across India to develop a similar kind of uniform quality standard for treating the stroke. Just outside having the tea, Dr. Kunal asked me that how it will be legally possible for us to take 5 hospitals as a hub and spoke, right? There will be 5 spoke as a primary stroke center and advanced stroke center. We are there, right, to help them. So there, the uniformity by getting the accreditation done makes things possible to you, that uniformity is maintained across India. Everyone is doing their own way. But if the uniformity is maintained in those clinical indicators, the parameters, if they are uniform, that less than 10 minutes physician will see, emergency physician will see the patient, less than 15 minutes the stroke team will see the patient, less than 60 minutes all will try to thrombolize the patient, less than 90 minutes all will try to do the thrombectomy, right? So these all uniformity, how you can achieve in the quality aspect. It is by developing a good standards for stroke, and that is where I will congratulate as a Secretary Indian Stroke Association to Indian Stroke Association for taking such a wonderful initiative last year in July 2022, where we started developing MOU with the Quality and Accreditation Institute and developed the stroke standards for accreditation. And I think they need a huge round of applause, the QA and the Indian Stroke Association. And after that, we put it in the public domain and started developing the uniform standards, because what has been told to me, correct me if I'm wrong, there is only United States of America and Canada where the stroke accreditation standards are there, and we are the 3rd country to develop them. So it was, thank you very much. So it was done in a very good manner, put in the public domain. And the first center which was, we went for the assessment was the Lalita Hospital at Guntur, right? So, and now more than, I think, 20 applications, 65 applications are there, and 10 hospitals are accredited. So this is the result. But what happened in this? We started developing a network where the things are done in the similar way, not in a different way that I do this way. When I tell you my hospital, when the assessors come to my hospital, we thought we are doing very good. We are doing 7 to 8 thrombolysis in a month and 3 to 4 thrombectomy in the month. When it is a peak, we have done even 10 thrombolysis. There are past who are trained in emergency, they are here, they know about it, right? And Dr. Swani is here. They are here, they know how in Zydus it was done. But when the assessor came to assess our hospital, what deficiency we found internally was very significant. And I think all the hospital who've gone under this process, Dr. Meenakshi, Dr. Kumar, they will all agree that we think we are doing things right. when somebody comes to assess us, then, and in a uniform manner, then we find our deficiencies, that how by triaging where we are deficient, where we can make the process more faster and do some good points in the clinical indicator. So that is the strength of accreditation and development of standards and uniformity, and give good quality of stroke management for across India. And it is just, I think, a tip of the iceberg which we touched, because we are not believing in doing the advanced stroke center to be accredited. As even the ICMR and Indian Hypertensive will agree, it is we have to reach to the district level. There are many companies who has taken this initiative where you go to the primary health center. Thanks to COVID, and Dr. Dhamija told that there are a lot of CT scans which are being placed in the district level and the local levels, right? That is because of the COVID, more CT scans were placed. So the importance is more of the primary stroke centers where the CT scan is available and thrombolytic drug can be done. And thrombectomies can be left to the advanced stroke center where they can develop a tie-up or MOU with the advanced stroke center. So the main initiative of accreditation and standard development is to reach more and more centers where treatment can be given. That is the primary stroke center and advanced stroke center, which are in the major in the metros, where reaching to the hospital is difficult. How you will make difference there also? In Bombay, you cannot ask to go to Powai from one place to another, right? Because of the traffic. If more and more hospitals are accredited and they are placed that they are advanced stroke center, that is more easy for the people who are suffering stroke to go to the nearby hospital rather than hospital publicizing that we treat stroke. So this is how I think will make a difference across India by getting the quality and accreditation for stroke. Thank you very much.
Thank you, Arvind. Thank you. Wonderfully explained. Baby was, means the conception was done in last year, July. Baby born in early this year and started crawling and is a toddler. Yes, it's an infant, I would say. And as you say, it's just 8-9 months old. Young, I would say, not old, young. A lot need to be done among the size of the hospitals and the population we have in India. But the well done ISA, particularly, I would say, to pump in to start the process for standardization. And I really like it. What you talk about is how things can be changed when you work together. And that's what the power of collaboration, working together. You can walk a mile, but together you can walk 10 miles. So that's very old saying, but it has been re-emphasized, not only the national, but the international organization, including World Health Organization. I think last week or last to last week, WHO DG was also mentioning about the same thing, collaboration. And I think that the CEO of the World Bank, Mr. Banga, he mentioned in his opening remark in the World Bank Assembly, just a big whack is about collaboration, how public-private partnership, government, state government, national government partnership, and the organizational partnership, along with the professional partnership of individual, really work better to give the better results. So thank you so much, Arvind. It's really good initiative. I'll come back to you in a moment, but I would like to move to the lady there, sitting there, Dr. Meenakshi. Congratulations, Meenakshi, first for achieving QA accreditation for your hospital just yesterday. So congratulate her for the achievement. As advanced center accreditation, they got it. So I think the very pertinent question to you would be, can you share some light for our audience on your experience about the process you underwent to achieve this accreditation?
Yes, definitely. Actually, my hospital, it's a family-run business. We have a 100-bed hospital. And typically at a district, it's a 3-tier town in Tamil Nadu, Erode. And we have all the facilities for an advanced stroke center, starting from full-fledged casualty, and we have a 3-theater OT complex with an advanced cath lab, intervention radiologist, neurologist, neurosurgeon, everything in place, but probably a better system that was required. So once this accreditation process started off, I think in Jan, I was probably the second person to apply for it. I had contacted Dr. Arvind, and I said, I want to go for it. So once I started, the whole process was first they sent us, I mean, it was such a, every stage they helped us. Because it was a family-run hospital. The system was different, unlike corporates. So at every stage, we used to have difficulties. There were so many policies. There was, I think, around 70-page booklet which was sent to us. And a lot of it, because I was more or less into the clinical side, never went much into the administrative aspect. So when I went through the booklet, it was all like Tom, Dick, and Harry. I was like, what is this? Oh my God, so many things to go through. But at every, then we started analyzing every part and trying to implement it into our own system at every department. I think that was what has brought in a huge change in our practice. I would like to say in the last 6 months, a huge change in the way we have treating stroke in our hospital. And thanks to QI for that. So the first thing was, from the start point, we had made changes, like from receiving the patient, as Sir said, receiving the patient at the security level to recognizing at the level of our reception, to our casualty, our staffs, our DMOs, our duty medical officers, our emergency physicians. So everybody has now been completely trained, and since the QI thing had started up, we can see a huge increase in the speed at which things are happening. So that is what I would say, that probably every hospital should start going for the accreditation process to standardize their own protocols and treatment for stroke. And because the main thing is you want to achieve the IV within 60 minutes, you want to achieve the thrombectomy within 1.5 hours, and of course, not only just the acute part, every part of our care is being standardized by QI. For example, the ICU care, the nursing care, the diet, including your physiotherapy, rehabilitation. So we have prepared new SOPs and we have standardized everything, biomedical engineering, electrical work. So we have new booklets and new things for everything. So I think this entire thing not only helps in stroke, but also to standardize the whole system has been put place for all other specialities as well. So I would really say that it was a wonderful experience. Of course, it was difficult for us initially, but I think now the system is through. And I would like to put this forward to a lot more centers around, so that it can be more unified, because I think we are probably the first in the surrounding districts. And few things that I would like to bring upon is, see, practicing in a small district hospital, I mean a district area, like it's a 3-tier town. One problem or challenge that I am facing when it comes to an acute stroke care is, out of 100 patients who are coming within the window period, almost only 10 to 15% are insured. The rest, 80 to 85%, all have to pay by cash. So this is one segment where we have a lot of difficulty in convincing them to take up IV or to go for a thrombectomy, even if we are doing it at very reasonable costs. So that is something probably the ISA and this one can take up. And probably we can have more number of patients who are insured, and how we can bring up this insurance policies more standardized for hospitals to deliver, especially private hospitals to deliver a lot of.
For gentleman sitting in the middle, Neeraj, actually thank you, Meenakshi, for sharing. And I'm sure what you mentioned about huge change definitely bring the better outcomes, clinical outcomes for your patient. So that's actually the main thing, is how you can, like Arvind was mentioning, all the indicators, door to needle. I'm not a neurologist, even a doctor, but door to needle, door to puncture, door to CT, door to MRI, door to lab, right? So all these are part of the standard which you have to demonstrate in real time to really execute those processes. So thank you very much for sharing your experience. So coming to linking your answer to the last says of to the Neeraj is about, like she mentioned, is about affordability, and part of universal health coverage is not just accessibility but affordability. Care without financial burden to the family is the principle of USC. Is what your thought, being a leader, the CEO of a hospital, running the systems, what are your thoughts on how we can make it more affordable on a wider perspective? Over to you, Neeraj. Thank you.
Yeah, I think it is a very important question what Dr. Meenakshi was talking. We were talking the same while we were having a tea outside. See, I'll give you two examples with two specialities. Like if you see the lowest rate in the world, which is known as CGHS, right? So except cardiology and joint replacement, all rates are pathetic. Even if I think a simple hospital in tier 3 cannot afford them. But why these rates of cardiology as well as joint replacement are very well? Because a campaign started by the doctors and they've approached the government of India. As a result, the joint replacement rates any private company can give as well as the cardiology rates. So I think three things are important. 50% of the business in any big cities is belong to credit, that is TPA and insurance companies. 20-25% government scheme, if at all your state, your city has, and rest is cash patients. So these days, 15 to 20% only you will get cash patients. So if you want to make stroke or a brain attack available to all the people, I think we have to do pitching with the insurance companies. I'll give you example of Apollo, like robotic surgeries. Apollo did 10,000 robotic surgeries. Apollo Ahmedabad, they have taken robot 7 months back. So everybody who is coming to your hospital, they're not affording the robotic rate because they are going by open or lab and it is costly. So we have taken a robo which is pay-per-use model. So we have invited the companies like ONGC, SBI, so on. Plus we have done a pitching for all the private insurance companies. And now, after 6 months of struggle, 50% of the insurance companies are paying for your robotic surgeries. So therefore, I think most important, like say for example, thrombectomy. You call any hospital, I'm giving example, and ask what is the rate for thrombectomies. Packages have not been made. Like some hospitals are making affordable packages or assured packages. So if we create these kind of packages, it is good for the insurance company. I am a part of insurance regulatory authority of India as an expertise for the rates. So if we make packages like average length of stay, it also include the length of stay plus physiotherapy. I think any stroke patient also require a physiotherapy. So if we make a package which also includes the length of stay as well as the physiotherapy, the insurance company will pitch in. And if you're not talking to insurance companies, so we cannot able to make affordable and accessible. And the real sufferers are not only corporate hospitals. It is tier 2, tier 3 cities also. And why the accreditation is very, very important. I'll give you example since I am the business manager for the hospitals. So one of the fertility chain, they have accredited around more than 40 hospitals. And now the private equity valuation of a private equity chain fertility is over 1,000 crores. Not even a multi-specialty, but one of the reason, I'm not telling you, one of the reason because they have quality system in place. They have a protocols in place. They have a clinical indicators in place. So by sitting, you can have a control over system and processes. So I think Indian Stroke Association, along with Voice of Healthcare, involvement of government, we can able to pitch to the insurance companies as well as corporates.
Thank you so much, Neeraj, for your perspective on the financing of stroke care and how it can be designed, amalgamated into the system so that we can really make use of this insurance mechanism, public or private, whatever is all about. And the next thing is about change, because change is very difficult, right? And I see the change. I'm into quality and accreditation for the last 25 years, started at NABL, then NABH, now QAI, nationally and internationally at many places. And we have always been complaining, I'm sorry guys, the clinicians, doctors sitting, we have been complaining the clinicians don't get involved into the quality and accreditation process. And it's not a false statement, it's a true statement. It was. Usually it is driven by the quality department, so-called quality manager, push things and get things done from clinicians. And this is the first time. This is the first time in India we see the change. Why? Because the stroke care accreditation program, I say, is a clinician-driven accreditation program. So can you please clap for all the clinicians, neurologists, stroke experts in the country who are really driving it. And I'm getting call from directors of premier institutes, both government and private. Dr. Rana, what have you done? I said, what happened? My head of neurology coming to me and say, I want this accreditation. This is the first time happening. Otherwise, quality manager comes to me and said, I want to do this and do that, and they don't cooperate. First time it is happening, clinician-driven quality. So congratulations to all of you for bringing that change in our country. And I'm not stopping in country, we are going beyond boundaries, which we already started. Now the second question, which is like this fireside chat, they say, quick questions and quick answers from you. Coming to Dr. Saxena, you see in the accreditation, congratulations to you also, Max Patpadgan, gone through the process of accreditation. Quick round on about your take as a clinician, implementing quality initiatives.
So that was such a wonderful mix. So we all feel that we are the clinicians, that job is of somebody else's, but actually it is our job. And we are being monitored by somebody else. So it is our own responsibility to monitor your own work, your own clinical parameters, and then show to the world and improve the health care and the patient care. So after the inspection which we had and accreditation we got, we had a feeling that we renovated our house and got it Vastu corrected also.
Fantastic. That's lovely.
So
that's great.
I think that is what we feel. Everything now streamlined in spite of the fact that at the hospital where I work, there's been quality department very active, and for the last 7-8 years we had almost 50-60 parameters were already being monitored across the chain of the hospital. But in spite of that, we realized that there are a lot of changes, a lot of improvement which had to take place, and the importance is the sustainability. You have to sustain that. That is why now I'm sure that every 6 months or 1 year, the team would come and again check, cross-check, what have you done after getting the accreditation. So that is where it's so exciting, and it's an evolving world. Everything changes, parameters, the protocols, they keep changing. So we have to keep pace with that, and as per the changes, the new protocols would be coming or would be getting modified. So as I say for the common people, whenever I get a chance, and we have to go beyond the boundaries, beyond being sitting in the chamber in the hospital, we have to go out and talk to the people about the educating them about the stroke, which is so relevant, because stroke, hardly anybody understands what is stroke. Whenever I go to a public gathering, when I talk to them, what is stroke, they are all confused, what are the symptoms, they are not aware, in spite of the fact it is so devastating, it is so crippling, life-threatening, but they don't understand it, only heart. So I tell them, dil hai ki manta nahi, aur dimag hai ki janta nahi. So what is this?
We got wonderful panelists, Vastu.
So we have to use those catchy words, so people have to understand ki it is must.
So change is must in our lives. So IHBAS was the first hospital, neuropsychiatric hospital in the country to get NABH accreditation. First hospital, and still we have continuing with that. It's a neuropsychiatric, NIMHANS followed us. So we also witnessed a sea change after that. And अपने काम की समीक्षा करना भी बहुत जरूरी है. That's what we should do every day. And that change is because of the passion. So we have one person in this audience who is a living example of how the change can be brought by mere passion. So that passion brings Dr. Nirmal Surya here. That, if we have that word neurorehabilitation in this country, he is a person and his passion has brought neurorehabilitation, a common conversation at least now. People are now talking about neurorehabilitation, which is still in infancy. It is all because of his passion and his work in last 20 years that we are now discussing a stroke rehabilitation, a Parkinson's rehabilitation, a rehabilitation at the state level, rehabilitation at the country level, rehabilitation at the international level. So along with me, I'm also a neurology ambassador for One Neurology in European Academy of Neurology. Dr. Nirmal Surya is also the neurology ambassador. And we are advocating the brain health, the concept of brain health in the community. So what has happened is WHO in its General Assembly last year on 26th of May 2022 has adopted a resolution where all the 200 countries, they call it member states, have an obligation to implement what they call intersectoral global action plan for epilepsy and neurological disorders, including stroke. So we are now obliged to implement IGAP in our country by the 2030. And that is a broader outline where we as a government, as a member state of WHO, has to work to implement those strategies so that we can bring down the neurological disorders, make the brain brain happy, healthy and happy. That's number one, and thanks to Dr. Nimal Surya once again for taking that issue at all levels in the governance. Second is, I just want to conclude by importance of brain health and how we can keep our brain healthy. Our brain capacity, which is just like a human capacity building, is also very important. Our brain is continuously exposed to stress and strains, whether it is disease or environment or genetics, all these things. So like a car, when you drive a car and you come across a steep hill or a steep unchai, you keep on changing the gears so that the car can maintain its speed and maintain that RPM. Similarly, our brain also has that resilience, has that cognitive capacity or cognitive reserve, where if it is exposed to exposure to an insult or a major injury or a vascular injury, then it can adapt if it has a reserve. If you have a bank balance of a good money, you can adjust to all adverse circumstances. Similarly, your brain should have that capacity or that cognitive reserve where you can face the challenges made by man or made by environment or made by disease or by the other organisms or by vascular risk factors. So 6 things which are very important to keep your brain healthy. That message should go across from this platform today. That is, number 1, cut down your salt by 50%. Salt reduction is known to decrease the incidence of all vascular disease, including stroke. So cut down your salt. Number 2, take vegetables, greens, fruits in a colored manner. All colored vegetables. At least 5 to 6 servings of your fruits and salads every day will keep your brain healthy. That is number 2. So fruits and salt. Cut down your sugar, irrespective of whether you are diabetes or you are a non-diabetic, cut down your sugar to half again. That is number 3. That will have a long-lasting effect. Number 4, try to cut down your pollution amongst indoor or outdoor pollution and exposures to smoking and the other environmental pollutants. Number 5th is your physical fitness. Exercise every day at least for 30 minutes or 10,000 steps at least 5 days a week. That is your physical fitness to make your body resilient and physical. It's not only weight reduction. It's in addition to weight reduction, you have to have a physically active life. And lastly is cognitive fitness. Cognitive fitness is fitness of your brain. Challenge your brain. Learn a new hobby, whether it is music or learning a new language, connecting socially with other people, with your family, friends. Make your brain connections very active and challenge them, because neurons do not, once you lose the brains, they don't come back. So keep them active so that you don't lose those neurons. Thank you very much for all these things. I think keep your brain healthy to have a healthy life.
Thank you, sir. Thank you very much. I think thank you for educating and informing us. We heard 10 commandments from Doctor there, and now 6 principles for brain health. So please, let's see how we can implement those things. Is it easier to get accreditation, very difficult to maintain? So guys, challenges for you. Quickly coming to Arvind. Arvind, ISA has been very active in improving all these things. How you see quickly ISA role in future?
Thank you. It was a wonderful session and wonderful comments by all the panelists. I will congratulate them all. We see a lot of challenge as an Indian Stroke Association for the accreditation further, because as I said in my previous talk, that we want to reach at the district level. So ISA want to request all the neurologists, nursing, rehabilitation, go back to your hospital, ask them to apply for the accreditation as Advanced Stroke Center, but it is a request for the Advanced Stroke Center to get 5 more center as a primary stroke center attached to it. Because the main aim is the people should receive the treatment. So that is the challenge for Indian Stroke Association. That is why we have collected all the stakeholders here with VOH. We thank them for that. And that is the major challenge for ISA to reach at the district level. And I think the partnership with the government, corporate, as Neeraj also told, it is not only that we can do with the public health, we have to involve different partners to reach to that level. That is the major challenge, and that is a wish for us. Then in another year, we have more than 200 hospitals accredited across India, in which 100 are primary stroke centers.
Wow, ambitious plan, I say. Thank you so much. Thank you. I wish that, yes, that dream come true quickly. Thank you so much for your initiative. Coming to Meenakshi, quickly, take home message for the audiences.
Take home message. All those who are having smaller hospitals should go for a primary stroke center accreditation. All those who have an advanced facility should go for it. This is going to unify the entire system and in fact have a completely better outlook. Your treatment outlook is going to change and better outcome for the patient too.
Thank you. Very quick, very crisp, very pertinent. And I think that's the whole idea behind is to create an ecosystem of stroke care, primary and advanced, and look back to each other. Don't shy that don't want to send a patient. Win-win situation for patient and the provider, both, so that you can refer to the higher center and then you can back to the follow-up for that. So I think that's very important. Quickly coming to Neeraj, from the administrative purpose, not on the clinical side, what's your message, if any administrator, or they can feed back to their administrator back home? Any quick message for...
So I just want to add brain health. I think he made a very important point. We in the hospital have health checkups, but I have hardly seen anybody who is doing a brain health checkups. So they do heart checkups, they do whole body checkups, but I think all the administrators sitting here, all policy people, why can't we have a mandatory brain health checkups? And I think if you get it done, people get to know more about that thing. That is one point. But last not the least, I think most important thing is approach insurance companies. That is a very important. Make the packages. I'm sure nobody in this room which is sitting here, they have a packages for stroke. Please make the packages for stroke. Insurance companies these days, whether a PPN or a private health insurance, they only accept packages which are every length of stay and include physiotherapy. Because I think that will only make a difference.
Thank you, Neeraj. You always do the business activities, So that's why he's telling how to increase business at the hospital, including package for brain health checkup. Very important for everyone. Thank you, each one of you. We don't have much time for but each one of you sitting there, you have a chance to interact with them after the break. During lunchtime, you can interact with them. I'm sure you would be available to them. Yes. Great. Thank you. They are agreeing in public, so you can interact with them. Thank you. But as we say, door to needle, door to puncture, as so on, I would say conference to hospital. Whatever you learn and understand, please take it to your hospitals and try to use those knowledge which you gain. So conference to hospital in real time. So thank you very much, each one of you, for your wonderful discussions and your deliberations. Thank you, each one of you, for your presence and listening to all these things. Thanks to VOH for organizing such a wonderful gathering where we bring a lot of stakeholders focusing on stroke care, and Indian Stroke Association being a wonderful partner for not only for this conference, for QA as well. Thank you all the ISA management and leadership for that. So thank you very much. With this, I would like to close this panel session. And if you have any questions, please reach out to them for interaction. Oh, you Dr. Nirmal Shuda, please.
Dr. Rana, what you have done. Would it not be a good strategy to involve all the district hospital, the government, to accredit them as a primary stroke accreditation? I think if you reach out to the district hospital, you are covering millions of patients. So rather than, one private hospital, reach to the government, get all the district hospital under the government to be stroke ready center. And
thank you so much for your kind advice, sir. I think it establishes the linkage between us morally and mentally. Yes, we started working on, and I think with the ISA also we are working to write down to the state governments. And also I had a chance to meet Dr. Meenakshi Sharma, who is leading NCD, particularly neurology brain things in ICMR. I think that's very important, and that's very important because that covers most of the patient in public and private both. It's not just, so district hospital like Dr. Dhamija mentioned, CTs in district hospitals, which is a requirement. So I think, So I think that's how we work, and that we should. Thank you for reaffirming our commitment and reminding us of what we should be doing moving forward. So thank you, ladies and gentlemen. Thank you, VOH, for having us here today, and thank you each one of you for your great presentations and deliberations in front of everyone. Thank you.
Just on the lighter note, Dr. Rana, if I may, don't write the brain off. There are movies where, people are open into coma, they regain their consciousness, and there have been so many movies made in Indian versions. Head injury leading to amnesia, and another head injury regaining that memory. So don't write the brain off. It is always capable of regaining and refunctioning. And second is, please don't go against the nature. Now, the one point which you all been highlighted very well by Dr. Dhamija and all the panelists here is don't fight the nature. Don't make day night and night day. Don't reverse that. That means sleep at night and work at the daytime. Thank you so much.
Thank you. Thank you. Wonderful education. Very good education session as well.
Thank you so much, all the panelists. This was such an engaging and interesting discussion. And thank you, Dr. Rana, for wonderfully leading today's discussion. I would now request you to please felicitate your co-panelist, Dr. Gowri Shankar. Dr. Arvind Sharma. Mr. Neeraj Lal. Dr. Sanjay Saxena. And Professor Dhamija. May I please invite Ms. Pinky Chahar to come on stage and felicitate Dr. Rana. Huge round of applause. I request everyone to please step ahead for a group picture. Thank you so much. It is now time for our networking lunch. Post-lunch, we will all reconvene and continue with our sessions. So please enjoy your lunch and take this opportunity to network and connect with all your fellow attendees. Thank you.